Welcome to the Regen Doc podcast, powered by dynamicathlete.com. I'm your host, Dr. Aneesh Garg. I'm Yale trained, Andrews trained, and a two-sport U.S. national team doctor here to help you make sense of regenerative medicine. The Achilles problem nobody talks about. You felt it during a pickup basketball game, or on the pickleball court, or halfway through a trail run. That tightness in the back of your ankle that turns into this bump, then a limp, then a burn, and now you haven't been able to run for months. The Achilles is the most important tendon in your body for movement, and when it starts to break down, the standard playbook fails most people. Let's get into it.
I've had Achilles pain for months. I've been doing heel drops, and it's not getting better. What now?
Yeah, if you think about this is a very, very common question. And I think the gap here is that when you start to load this tendon, there are a lot of things that are occurring that break this down. So recreational athletes age 35 to 55, from an Achilles standpoint, have surged in terms of injuries, especially with pickleball and court sports. Basketball, you start to look at it, and you look at even pro basketball, where they're having a plethora of Achilles tendon injuries. And you're wondering, why is it people are going down every single time? Or you start to see this player got hurt or this player got hurt, and you start to look at what can cause this. So eccentric loading works really well in early tendinopathy. So what is it? So essentially what you're doing is weight bearing stretching on that tendon to try and stretch that out. A very simplistic way of detailing that. And then tendinopathy, we talk about where it's actually more chronic than that inflammation period. It's actually tissue tendon degradation. So when that tendon is degraded past that threshold of that tissue degradation, the loading alone can't rebuild it. So then what do? Most Achilles tendon injuries and ruptures happen in tendons that were already degenerating. The rupture didn't come out of nowhere. So it's almost like the adage, the straw that breaks the camel's back, right? I use this a lot in the clinic where I drop my pen as the straw on the table and I go, why does this one straw, I just dropped the pen, why does that break the camel's back? It's because it's been building, right? And so nobody tells the patient that chronic Achilles pain is a warning sign for a much bigger problem, which is that Achilles tendon rupture. So I think that's really the big thing, that the tendinopathy, that thickening of that tendon, precedes most of these tendon injuries, especially from a rupture standpoint. So that's when people say, I've been doing my PT, I've been doing these heel drops, it's not getting better, what do?
Can I just push through Achilles pain if I warm up enough?
It's not a warm-up problem. And I think that's what people get wrong, is warming up a degenerative tendon or tissue degradation isn't the problem. So if it loosens up and tightens back up again 10 minutes later, or you feel it during your run, or you're going up and down the court, that's not a warm-up issue. That's a tissue quality issue. And I think that's the biggest thing when you're dealing with the Achilles tendon. And I think that's where you get athletes with a different mindset. When we talk about, let me just push through this. It's not that big a deal. Or I'm just getting older, right? We hear that a lot, where it's just, I'm getting older, or there's nothing that can be done about it. Or we've said on a different podcast where you got to live with it. And then I get soapboxy and I say, that's a lazy answer. So, I think that's really the big thing. So pushing through is exactly how recreational athletes end up with a full rupture and a 9-month recovery if they're going down the surgical route, right? And I think that's really that component where you're looking at, well, how do I make a difference here? And what are some of the things that you can do? But by and large, that's where people get things wrong is, what if I just heat it up, warm it up, do whatever, do some of my stretches and things like that. Look, if Achilles tendinopathy and Achilles injuries would be benefited by stretching, then they would just heal from stretching. But everybody stretches and they don't get better. Stretching is not the answer for Achilles tendinopathy. So if you've got an Achilles injury, that's actually not going to be helpful for you. So this is where, just to be informed. So if you feel like this is hitting home, I would encourage you to go to dynamicathlete.com, read about this stuff, read about some of the things that you can actually do to help this before you get a full-on Achilles rupture. So I think the old commercial where it talks about the more you know, and I think it was an old NBC commercial where the more you know. I mean, I think that's what this podcast is about. So how do you become more informed? So certainly dating myself here. I doubt there's going to be a lot of people that are under 40 that maybe know what I'm talking about there. But yeah, I think that's what people typically get wrong. And this is where you can educate yourself, and just go to dynamicathlete.com and read up about a bunch of stuff. And certainly there's a section on Achilles injuries and Achilles tendinopathy on the website.
What should I do to actually fix my Achilles instead of just managing it?
I think the big thing is getting the true diagnosis. What is it, right? Is this really Achilles tendinopathy? Is this Achilles tendonitis? Is it coming from somewhere else? Does my Achilles actually look really fine? And is this coming from my hips or knees or whatever? And I think that's really a big thing. One of the nice things about going to even our clinic is where you have ultrasound and you can dynamically check the motion of that Achilles when you're flexing or moving your foot around in that space. So I think an ultrasound evaluation is huge. How thick is that tendon? You have two of them, right? Unless both of them are banged up, then you compare it off to the one that's not injured and you sort of see, is there thickening? Is there disorganization? Is there partial tearing? Is there calcification? Right? So you're really trying to get a good handle on what's the problem? What are we dealing with here? And once you can do that, then you can have a game plan forward. But I think the hardest part is being in the dark. You don't know what's going on. And then what do you do about it? Right? I mean, we talk about that a lot in the clinic is, what is it? And what are we going to do about it? And what are we going to do if that doesn't work? Right? And that's, I think, a big component of what actually matters in terms of how you go about it. And so in our office, we use EMTT and focus shockwave and radial pressure waves. So all three that go into it. Remember, we've talked about this. Radial shockwave isn't true shockwave, so nobody should be calling it that. It's radial pressure waves. So the combination of those three make a huge impact. And in fact, Achilles tendinopathy was one of the first indications from an FDA standpoint for shockwave. So if people are asking, well, what's the science or what's the research behind it? That's the one that has one of the most definitive research components to it. So I think that's really the big thing. And it's proven to help remodel and stimulate repair in that Achilles tendon. So when you create that environment for healing, then your body can take over and do what it needs to do. And so the earlier you do it, the better it is. So you may not need PRP or you may not need stem cells in that regard if you're taking care of that. So I think in the early going, you can get by with the EMTT, focus shockwave, and radial pressure waves. And then if there's another level to this, say it's more chronic or whatever, or it's a worsening than just the original or a really beginning Achilles tendinopathy, that's when you can layer PRP with it or stem cells. And that's really, you're changing the architecture of the tendon from the inside out. And I think that makes a huge difference. And people respond remarkably well to this.
Have you treated someone who almost ruptured their Achilles?
Yeah, we had a woman who actually raced cars and was told that she had to give up racing because she had severe Achilles tendinopathy. She'd gone to 4 different places and they all told her, well, you probably should give up that activity. It's a lot of, back and forth with your foot. It's going to be a problem. And she's tried some of these other things like just ultrasound or stim. She's done her PT. This is like going on for a year and a half, and significant degeneration of her tendon. And I remember her coming into our office and we started talking about this, and I looked at her and I said, yeah, I think we can help you. And here's how. And she started crying, tears just rolling. And I asked her and I said, what's going on? What had you so emotional? And she said, you've given me hope. And I said, what are you talking about? I haven't done anything. Literally, we've just been talking about this. She said, yeah, but you think you can help. Everywhere else I've gone, I said, I have to give this up. And I said, to me, that's not an acceptable answer. That may be the case at some point. I don't know. But right off the jump, that's not an acceptable answer for me. So we get to work with her. And we're doing EMTT, we're doing focused shockwave, we're doing radial pressure waves, and she starts to feel the difference. I mean, if you saw her when she walked in to where she was during that progression, you would have thought she was a different person. She was dejected, just sort of really sad, and understandably so, right? This is something that she wants to do and continue. And she's been told by multiple people that she trusts and respects that you have to give up your passion. And then we're starting to make a headway with her. And then, so she was pretty severe. So we had to do PRP with her as well. Super nervous. She was super nervous. And I remember just going through that process with her and taking it step by step with her. And it's really fascinating. So we fast forward a little bit. This isn't so much about fixing the pain. This is actually fixing the tendon and actually looking at the structure and how do we make an impact from there. So, you can see the ultrasound changes after the work that we've done, and she's back racing cars. I mean, that's awesome, right? I mean, I think there was a resignation that she wasn't going to be able to do what she wanted to do, and felt like that was her path forward. And she couldn't, and she didn't want to accept that. She couldn't accept that. She didn't want to accept it. And I think having that pathway and that buy-in really makes a huge difference. So she's one of our favorite people in the office. I mean, honestly, I would say 99%, if not everybody is pretty special in our office. I think we're pretty lucky to have really good people. We talk about building relationships first and taking care of people second. And she's a really good example of that. I mean, you sort of consider people that come into our clinic like family. And we talk about this on other shows where our whole design is, if this person was in our family, would we do this? And that's the way that we go after it. And so she's awesome. When she listens to this, she'll know who I'm talking about, or that I'm talking about her. And hopefully it'll put a smile on her face, because we love seeing her when she gets in the clinic, just to say hi when she's in the area.
What's the one thing you wish every Achilles patient knew?
I would say don't ignore it. That's going to be the biggest thing. It's telling you something, right? It's this warning sign that's saying, hey, there's something going on here. Hey, there's something going on here. And then if you don't address it and you continue to ignore it, then it's going to keep going. And I think it goes back to the same thing about, do I take care of something early, or am I just going to push through and then it's going to be worse on the back end of it? So I'm a big proponent of addressing things earlier. A, it's going to be less downtime. B, it's going to be more cost efficient because you may not need PRP or stem cells. So if you can get away with something less than that, then that's fantastic. So I think that's really the big thing. Otherwise, you're gambling, right? You're almost like flipping a coin, whether or not you are going to tear it or not. And this is where we've actually even talked about in-season prevention, where it's almost a prophylactic or preventative measure to get some of this treatment and try and increase blood flow into that area where there's not really great blood supply. So I think that's the big thing. Getting an ultrasound is super helpful, not necessarily an MRI, especially because you can use it dynamically. You can look at the tendon quality in real time. You can look at the actual the movement and how it's working. Again, MRI is fantastic for a lot of things. Ultrasound's also fantastic for a lot of things, and just especially from a movement standpoint. I think fundamentally, if you're looking at something that requires movement and you're able to do so, the ultrasound is fantastic. And I think, but you need to know what you're doing with that. And then I think the other thing too is that if you're able to identify what the problem is, then you can have a clear path forward. So I think that to me is a big thing. So what I would tell people is, like, most Achilles ruptures are damaged tendons already. And so there were probably warning signs beforehand that people ignored or pushed through. And so that's one thing. And the other thing too is that if your Achilles sort of loosens up and then tightens back up, it's sort of this push-pull. I think you should definitely get that checked out and make sure that it's not becoming a bigger problem. And then, like we just talked about, the ultrasound is a really underutilized component to this. And I think it does a really good job in comparison from an MRI standpoint. So even if people have an MRI, we like to ultrasound in our office because of those things. Like, can we look at what the tissue is actually doing with movement and where you're getting restricted? So to me, that's really the big thing. I think if a lot of this stuff is new or you're wondering where can I get more information, I think jumping on dynamicathlete.com, trying to read about this stuff, certainly read about EMTT, focus, shockwave, radial pressure waves. You look at PRP and stem cells, that can make a big difference here. And how do you do this really even before you have an Achilles rupture, or even potentially afterward, even post-surgically? A lot of these things can help if you end up having to go down that road, or if you've already gone down that road and you're like, shoot, I wish I had known, and you're still having pain. This is something that certainly can help you. And I would encourage you to be informed, get some information, and then sort of see what options are for you, because this is something that you can take care of in the early going and you'll be much better off. So hope this helps, and we'll see you next time.